مساء الخير. This is my last presentation of the meeting. I again يعني extend my thanks والله للإدارة المنظمة for my invitation. البرزنتيشن بتاعتي دي عن updates in laser vision correction for corneal repair. By corneal repair I mean irregular corneas, not the straightforward, not the standard virgin refractive cases that we have all the time. So if you do have an irregular cornea, what are the challenges? What are the limitations with the classic wavefront guided treatment? I've been doing wavefront guided treatment over the past 20 years. دكتور أسامة يعني أنا تلميذه في الموضوع ده والحقيقة we've had marvelous results, and we all lived the hype of aberrometry and Zernike and everything, but there was limitations أو ده كان زي ما يكون في handicaps كده للwavefront guided treatment, especially in irregular corneas. Now, if I would like to speak about the shortcomings of wavefront guided technology, I can go all day. بس هي الفكرة كلها in this subcategory, subcohort of patients where you do have an irregular cornea, wavefront guided ablation لغاية النهاردة sometimes is not the way to go, because we cannot get an aberrometry in a lot of cases. Back in the day when we had the wave scan, and even when we upgraded to the eye design, in a lot of cases we could not have a good aberrometry. Sometimes in patients that had perfect corneas, if the patient is pseudophakic, the machine would not read. So if we get a scan that is not reproducible, نبص بقى على السكانز يبقى عندنا 4-5 scans for the same patient, same eye, and then you trust one of them and take a leap of faith and say, I'm going to treat this wavefront error. Even if you do that, and even if you have chosen correctly, and this is the wavefront error of the patient, sometimes the problem is you will have to treat the whole wavefront error, including the low order aberrations and the high order aberrations. So these patients, they do have very, very dear, very expensive corneas. They don't have that much of a thickness in the corneas, and you only want to smoothen their corneas, and you end up in keratoconic patient, for example, with a refraction of -5, with a -4 cylinder, and a bunch of higher order aberrations. You're stuck in treating the whole combo, the whole thing, and not only the higher order aberrations. So in a lot of patients, you would refrain from doing them, because if you are going to ablate this cornea, you'll end up with a much thinner and weaker cornea, and you'll actually aggravate the keratoconic problem. So the recruitment of these cases were really limited. Yeah. Then came the era of topography-guided ablation. We all rode the wave of topography-guided ablation, and this was, of course, mastered by Alcon Wavelight. And it had two modalities, the topography-based ablations and the tomography-based ablations. The real beauty about doing topography-guided ablation in these patients was not the result of or the ablation power of the machine to regularize high order ablation, but it gave you a choice of treating the lower order aberrations or not. So in most cases we would opt only to treat the higher order aberrations and leave the lower order aberrations at bay. By this we limited the ablation depth in these cases, and we could include more patients for this type of treatment. But in spite of our ability to treat only the higher order aberrations, the corneal higher order aberrations, and at the amount of sphere and cylinder which you would choose, just sprinkle a little bit of sphere and cylinder to decrease the thickness of the patient's spectacles, we had to treat all higher order aberrations. We could not choose some higher order aberrations to treat and other higher order aberrations to basically ignore. So what happened in these patients, so this might not sound like a big deal. So what if we don't, what if we have to treat all higher order aberrations? In keratoconus and specifically, or any hyperprolate cornea of the sort, the amount of negative spherical aberration, as we all know, is extremely high. These are the patients that when they develop cataract, you should not implant one of the fancy lenses with the minus spherical aberration. This high spherical aberration does not affect the vision of the patient. The patient sometimes sees halos, or even a lot of times sees halos, but the amount of contrast, the thing that really affects the vision is not the spherical aberration at all, but is the coma. So in these patients, in the hyperprolate corneas, in the keratoconic patients, is coma as equal as the spherical aberration? The answer is no. The patients, they have a very high amount of spherical aberration, while a minute amount of coma, sometimes a really minute amount of vertical coma, which is doing all the damage to the contrast of the patient's vision. We were very, very fortunate to do a lot of topography guided ablations in irregular cornea, so we mastered things like the topography neutralizing techniques, which is basically, if you're going to treat the spherical aberration or the higher order aberrations, you will induce with your treatment lower order aberrations. So how to predict the amount of sphere that you are going to induce and treat it while it's not there yet, so to avoid of this sphere unmasking after you do the surgery. We did a lot of this, and we did a tomography modified refraction. Would you treat the astigmatism in the axis of the topography or the axis of the manifest refraction, or somewhere in between? This is a subject of other presentations of mine. But again, we were good at topography neutralizing techniques. We were good at tomography modified refractions, but we had this theory of not the spherical equivalent, but the astigmatic equivalent of higher order aberrations. So if you're going to treat the manifest refraction, then do a standard ablation. If you are going to do one of the fancy topography guided ablations, then you should stick to the chromatic axis and so forth. But we could not transfer our experience efficiently to our fellows. It needs a long experience, lots of eyes, and lots of feedback for you to sort of evaluate your own recipe. And we had to treat spherical aberration along with coma. So this is my grandchild. I made him pose for this. So I think the best strategy in corneal repair work, if you can treat the higher order aberrations alone and leave the lower order aberrations. If you can even choose to treat some vision determining higher order aberrations, and with the years, along the years, we now know that the coma aberrations are the higher order aberrations that really affect the quality of the vision. If you can tame your myopic pattern by decreasing the depth, if you can tame the hyperopic pattern by decreasing the volume, and if you can sprinkle some refraction correction on top, then this is the way to go. And this is how I treat irregular corneas now over the past, like, let's say, before the COVID era, like 3 or 4 years. I don't think it's 4 years, I think it's 3 years. We actually choose the higher order aberrations to treat, and I only choose the coma. Sometimes I leave the machine itself to choose whichever higher order aberrations it wants to choose, but again, I always go for the coma and leave the spherical aberration. We have loads of cases that are much better after the surgery. I have not experienced improvement in these. I've always had a feeling that these patients, they have a ceiling of improvement, that they will not improve beyond a certain point. Some of my patients are really seeing good after these patients. Now, this is something that we need to look at. In these patients, if you take a look at the higher order aberrations, you will see that preoperatively from postoperatively there's just a mild improvement, like a 0.2 diopter improvement. But this 0.2 diopter was the 0.2 diopter induced by coma. This is the only refractive error that degraded the vision that much. This patient, actually, if you can take a look at not the point spread function, you can take a look at the point spread function, but take a look at the Landolt charts as well, and you can see the difference in the clarity of vision of this patient after you just treat 0.2 diopters of the higher order aberrations. So if the ablation depth is small and you want to select a higher order aberration treatment only, would you go with a premium ablation profile? The answer is yes. So would you go for a topography guided ablation or a wavefront guided ablation? This is a big question. So if you have an ocular higher order aberration greater than the corneal higher order aberration, now you should weigh the difference between both. So if the higher order aberrations of the total ocular higher order aberration is much less than the is much more than the corneal higher order aberration, then definitely go for a total wavefront guided treatment. If it is just a little bit more than the corneal higher order aberrations, then go for the corneal wavefront. Why? Because we do trust the tomographies much more than we trust the aberrometers, especially the Hartmann-Shack aberrometers with their inherent weakness of doubling. But if the corneal higher order, and this is something that we see all the time, and this is something that I've seen a lot of my colleagues, especially the junior colleagues, do. If you see that a patient has high corneal higher order aberrations, while the total higher order aberrations of the whole optical system is not that high, a lot of my colleagues would opt to do a corneal wavefront treatment, which is the wrong thing to do. Why? Because in these patients, there are a lot of intrinsic or inside the eye higher order aberrations that are actually neutralizing a lot of what's happening in the cornea. So if you decide to heal the cornea and the cornea becomes perfectly smooth, you will unmask a lot of higher order aberrations that are actually produced from the backside of the cornea and the other components of the eye. So in these patients, never do topography guided ablation. I think in conclusion, smoothening an irregular cornea is always challenging. When successful, it leads to a considerable boost of the visual acuity. In these cases, decreasing the lower order aberration is a secondary target. So our primary concern is not for the patient to take off his glasses. Ablation depth is a primary concern, and if ablation depth is always our concern in these patients, it's a super valuable concern. By giving the option to treat the coma, especially the vertical coma, and spare other higher order aberrations, this allows us to eliminate the vision distorting higher order aberrations while preserving very valuable corneal tissue. Thank you so much.